In this lecture, we are going to go through the world of drugs used in ophthalmology. And here you can see the headings that we are going to go through. We'll start with definitions in this world of pharmacology. We are going to describe the routes of administration, the packaging standards of the ophthalmic drugs, how the ophthalmic drugs are absorbed, and what are the different forms of eye drops. And then we shall have a quick look at the autonomic system mediators, then the drugs used as mydriatics, those used as miotics, and those used in anti-glaucoma, and finally we are going to go through ophthalmic anesthesia. Now we shall go on with some definitions, and to start with, a drug is a chemical substance that induces changes in the body physiology. And the science of pharmacology is that science dealing with drug actions. And the science of toxicology is the science dealing with adverse effects of chemicals in the body, with the two technical terms pharmacokinetics and pharmacodynamics. By pharmacokinetics, we address the fate of substances administered to the human body. That is, what the body does to the drug, being absorbed, distributed, metabolized, or eliminated. And by pharmacodynamics, we study the biochemical and physiologic effects of the drugs in the body. That is, what the drug does to the body. Drugs for ophthalmic use may be administered through all the known routes of administration. Basically, they may be administered topically and in addition to being administered orally, parenterally, and by injection periocularly, in addition to intracameral, that is, injection inside the anterior chamber, or intravitreal, that is, inside the vitreous cavity. There are packaging standards known in the industry for color coding of the different drugs. Mydriatics and cycloplegics are coded by the color red, and we all know that mydriatics have the cap of the eyedropper red. Miotics are coded green, beta blockers are coded yellow, non-steroidal anti-inflammatory drugs are coded gray, and carbonic anhydrase inhibitor eye drops are coded orange. Now we come to factors affecting drug absorption from the surface of the eye. And these include four factors. The first is the solubility of the drug, whether this is lipid or water soluble. The second is the gradient of concentration between the outside of the surface cells and the inside of the cells. Third is the presence or absence of damage to the corneal tissue. And finally, the form of presentation of the drug. For a drug to pass through the cornea, it should be both lipid and water soluble. Lipid soluble drugs are nonpolar or non-charged compounds, and in this way they can pass through the epithelium and endothelium. For water solubility, the drug is polar and charged, and hence it can pass through the stroma. A concentration gradient results in passive absorption, that is, a process that is not energy motivated, and the drug passes therefore from the higher concentration to the lower concentration. The third factor, once the epithelium is denuded
or abrased or removed. This is a factor that increases absorption, and therefore there might be an unexpectedly high concentration in the eye. Now we come to drug forms, and we start with the aqueous form of eye drops, and this is the commonest form. It has the disadvantages of having a short contact with the cornea and short time of absorption. Now, ointments. These are the known fatty preparations. This preparation in itself prolongs drug contact time with the surface of the eye and therefore are useful in children. You don't have to instill irritant eye drops to the child so many times, creating resistance. And you should know that the administration of an ointment may preclude entry of subsequent eye drops. The drug may be presented in a device, for example, the Lacrycet, which is a rod of hydroxypropyl cellulose used for treatment of dry eye. It can be inserted in the inferior fornix with a special shaped applicator. It absorbs fluid, swells, and then releases the active ingredient over a period of up 24 to 24 hours. Another example of devices is the OcuSert, which is a membrane-bound insert that can be placed onto the bulbar conjunctiva under the lids, and it delivers pilocarpine for up to 1 week and is useful in treatment of glaucoma patients. With respect to autonomic mediators, there are two main mediators in the autonomic nervous system, and these are the acetylcholine and the noradrenaline. Acetylcholine is present in all ganglia and in all postganglionic parasympathetic nerve endings, in the skeletal neuromuscular junction, and in only some postganglionic sympathetic nerve endings, while noradrenaline is present in all postganglionic sympathetic fibers, nerve endings, except sweat glands and in those involved in dilatation of the blood vessels and skeletal muscles. Cholinergic receptors, that is, receptors of acetylcholine, are either nicotinic or muscarinic, and nicotinic receptors are present in the ganglia and the neuromuscular junction, while the muscarinic are present in the postganglionic parasympathetic nerve endings. The adrenergic receptors, that is, the receptors of noradrenaline or norepinephrine, are found at the postganglionic sympathetic nerve endings and are classified into alpha and beta receptors. Now, Botox, the known toxin produced by the bacterium Clostridium botulinum, has the mechanism of action of blocking the release of acetylcholine at the neuromuscular junction and therefore leading to temporary localized flaccid paralysis for 3 to 4 months. And this effect is the one made use of in cosmetic procedures like abolishing rhytides in the skin. Now, the adrenergic receptors, as we said, are classified into alpha and beta receptors, and alpha receptors are either alpha 1 or alpha 2. Alpha 1 are in the arterioles, the dilator papillae muscle, and molars muscle, which is a part of the levator palpebrae superioris, as you all know. And the alpha 2 receptors are found in the ciliary epithelium, that is, the epithelium of the ciliary body, and their effect is to decrease the aqueous formation and increase the uveoscleral outflow, and therefore alpha agonists lead to drop of intraocular pressure. Beta-adrenergic receptors are again classified into beta 1 and beta 2, and beta 1 receptors are cardiac, found in the heart muscle, and once stimulated they lead to tachycardia, while the beta 2 receptors are found in the ciliary epithelium and have a contrary effect to the alpha 2 receptors, that is, they increase aqueous formation. Therefore, the anti-glaucomatous drugs here should be a beta blocker. We must notice also that the same beta 2 receptors are present in the bronchi, and their effect is bronchodilation, and therefore beta blockers lead to bronchoconstriction and attacks of asthma. And this is a side effect of beta blockers used in the treatment of glaucoma. Now we shift to another title, which is mydriatics, and mydriatics are the drugs used to dilate the pupil. And from what we said, we can easily say that mydriatics can be either parasympatholytic drugs, that is anti-parasympathetic effect, or sympathomimetic drugs. Parasympatholytic drugs are muscarinic blocking drugs like atropine, so collectively known as having an atropine-like action, and their effect on the ciliary muscle is cycloplegia. The sympathomimetic drugs have no effect on the ciliary muscle, but they're directly acting on the constrictor pupillae and have no indirect action. Atropine is a very important drug. It is a naturally occurring alkaloid that is extracted from the plant known as Atropa belladonna, also from the plant known as Datura stramonium. Its mode of action is parasympatholytic, as we said, and it is a competitive antagonist of acetylcholine. Eye drops preparation might be in the concentration of half, 1 or 2%, while ointment is in the concentration of 1%. Atropine has the following actions in the eye. First, it dilates the pupil. Second, it is a cycloplegic. Third, it decreases secretions. Fourth, it increases the intraocular pressure, especially in old age or in hypermetropes. The action of atropine on the eye is prolonged, especially that of dilatation of the pupil, and it may last up to 10 days. Cycloplegic effect may last even longer than that, for up to 2 weeks. Its clinical uses include refraction in children who have a very strong ciliary muscle, treatment of iridocyclitis for pain relief, rest of the ciliary muscle, prevention of formation of posterior synechia, and finally a rare usage is in central retinal artery occlusion, where it might be injected retrobulbarly for vasodilatation. Its side effects are poisoning, and this results in the very well-known picture of redness, dryness, blurring of vision, hotness, tachycardia, and generalized sensation of madness. Its treatment is by physostigmine, which is iserine, a lipid-soluble drug that may reach the central nervous system, and the dose of the treatment is 1 milligram injected subcutaneously, repeated every 15 minutes. Another drug with atropine-like action is homatropine, which is a synthetic 2% drops. It has the same atropine action, but with less potency, and it has the same clinical uses of atropine. Now, cyclopentolate is another parasympatholytic drug that is synthetic in nature, with potent but short-lived action of a shorter duration. It has the same uses of atropine, but better in cases of allergy to atropine. Tropicamide, the well-known commercial preparation Midrisil is a synthetic analog of atropine, again, with mydriatic action, with a weaker cycloplegic action, and available as 1% eye drops. Now, phenylephrine, commercially known by is related in structure to adrenaline, that is a sympathomimetic mydriatic drug. It has a potent alpha stimulant effect and a weaker beta stimulant effect. Available in two concentrations. First is 2.5% and the second is 10%. Its full mydriatic action may last for up to 1 hour. It has got drawbacks of releasing the iris pigment, probably clouding the cornea, especially in higher concentration, and also elevating the arterial blood pressure, especially in the 10% higher concentration. It has the clinical uses of prevention of meiotic cysts and correction of ptosis that is seen in Horner syndrome, which is unilateral sympathetic lesion. Non-steroidal anti-inflammatory drugs. We have the two preparations of eye drops. The first is Ocufen. Scientific name is fluorbiprofen. The second is Acular. The scientific name is Ketorolac. They are both antiprostaglandins, and the prostaglandins in the eye have a meiotic response that is initiated during intraocular surgery, completely independent on the sympathetic parasympathetic system. Therefore, its clinical uses are inhibition of intraoperative meiosis during ocular surgery and prevention of cystoid macular edema. Now we come to meiotics, the drugs that constrict the pupil. And these are divided into two categories. The first, the direct acting, which act directly on the constrictor pupillae by the parasympathomimetic effect, like pilocarpine, methacholine, known commercially as Mecolil or Myocol, and carbachol, known commercially as Doril. The second group is indirectly acting by inhibiting the enzyme cholinesterase, and therefore known as anticholinesterases, and these are either reversible like physostigmine, known as Iserine, trade name, or the much more toxic irreversible organophosphorus compounds used as insecticides, and the two known preparations are ecothiopate, scientifically phospholine iodide, and tasmilen, scientifically dimicarium bromide. Now, pilocarpine is an alkaloid from leaves of Pilocarpus jaborandi, originating in South America. Its action is muscarinic of acetylcholine, not affected by cholinesterase system. Preparation is 1 to 4% eye drops, may be used as Ocucert, as we said before, or as pilocarpine gel known as pilopine. Actions of pilocarpine are meiosis that lasts for a few minutes to 6 hours, spasm of accommodation for 1 hour. At recovery, attempts at close work do not cause the spasm to return, and this is an advantage over Iserine or physostigmine. Its clinical uses are in chronic simple glaucoma, more modern name is primary open-angle glaucoma, to reverse mydriasis, for diagnosis of Ades pupil, and preoperatively before penetrating keratoplasty or laser iridotomy. Now, Ades or tonic pupil is a common cause of anisocoria, that is, mismatching between the sizes of the pupils of the two eyes. It's unilateral in 80% of cases. It occurs in women at the third and fourth decades of life. It is a manifestation of denervation of postganglionic supply to the sphincter pupillae and ciliary muscle. It's tonic prolongation of all reactions. Reaction to light is poor, reaction to near stimulus is tonic, reaction to accommodation is slow, and its diagnosis depends on using a parasympathomimetic like mecolil or pilocarpine in the concentrations shown here, 2.5% for mecolil or 0.125% for pilocarpine eye drops, instilled into both eyes. The affected pupil constricts due to the denervation hypersensitivity, while a normal pupil will not react. Now we come to anti-glaucoma therapy, and we shall go through the evolution of using drugs in treatment of glaucoma. First, treatment with myotics was invented 100 years ago, and then epinephrine and oral carbonic anhydrase inhibitors were added in the 1950s. Beta blockers were a breakthrough in 1978, followed by the use of alpha 2 agonists. Then the topical carbonic anhydrase inhibitors came later, followed by the use of prostaglandins and their analogues and derivatives, and finally the neuroprotective drugs, which have a role that is still under investigation. Now, myotics in treatment of glaucoma have the advantages of being cheap and very effective, but the disadvantages of defective vision with even minor lens opacities and the induction of accommodation spasm. Frequent application may be effected through the OcuCert that was described before, and the pilocarpine ointment known as pilopine. Now, epinephrine or adrenaline has the action of increasing aqueous outflow and decreasing aqueous production as an alpha agonist. It has the advantages of no meiosis or spasm of accommodation, but has the disadvantages of probable allergy, adrenochrome pigmentation, slight mydriasis, cystoid macular edema, and systemic side effects like elevation of arterial blood pressure. Dipivalile, known under the trade names of propine or glaucothiel, is a prodrug that is transformed into adrenaline in the eye, has the advantages of penetrating the cornea 17 times more than adrenaline, and has no systemic side effects, but still having the disadvantages of mydriasis and cystoid macular edema. Systemic carbonic anhydrase inhibitors, that is taken orally or parenterally, have the action of decreasing aqueous formation and have the advantages of being very potent, decreasing the intraocular pressure by 40 to 60%. The preparations are acetazolamide tablets, 250 milligram, commercially Diamox, dichlorphenamide tablets of 50 milligram, known under the trade name of Oratrol, and methozolamide tablets of 50 milligram. The doses are for acetazolamide up to 4 to 6 tablets per day. Action appears in 1 hour, reaches a peak in 4 hours, and lasts for 12 hours. The other drugs are taken in the form of 1 to 2 tablets daily. They have the disadvantages of paresthesia, malaise, gastrointestinal reactions, blood discresis, and probably renal stones. Now the hyperosmotic agents are topically or systemically used to increase the osmotic pressure of tears and or plasma relative to that of the eye, with the result of fluid moving from the eye to a hyperosmotic tear film or plasma, therefore decreasing the osmolarity of the eye and decreasing its tergence. Topical agents are hypertonic saline 5% or glycerin with topical anesthesia, as glycerin is very stingy in the eye. The systemic agents are mannitol, glycerin, and isosorbide. Mannitol in a concentration of 20% in a dose of 5 milliliter per kilogram body weight. Glycerin 50% concentration in a dose of 2 ml per kilogram, and isosorbide sugar in a concentration of 45% taken in a dose of 1 to 3 gram per kilogram body weight. They have the side effects, the potential side effects of cardiovascular overload, especially in patients with peripheral heart failure, urinary retention, especially in prostatic patients, headache, nausea, and mental confusion. Now, beta blockers in treatment of glaucoma have the action of decreasing aqueous production and have the advantages of being effective, used only twice daily compared to myotics, and may be used as adjuvants to myotics and oral carbonic anhydrase inhibitors. The disadvantages are locally corneal anesthesia and punctate keratopathy, and systemically may decrease the pulse rate and the arterial blood pressure, and may cause bronchospasm. They can be classified into non-cardioselective and cardioselective, and the non-cardioselective, like timolol and levobunolol. Timolol is known by the trade name of timolol as well, and levobunolol known commercially as betagan, and these are the concentrations. They are equipotent at both beta 1 and beta 2 receptors, while the cardioselective betaxolol or Bitoptic is more potent at the beta 1 receptors, and therefore its bronchoconstrictive effect is minimized. Now, alpha adrenergic agonists, as we said before, decrease aqueous formation and increase uveoscleral outflow of aqueous. The drugs are apraclonidine, non-commercially as lopidine, and brimonidine, non-commercially as alphagan. Apraclonidine is FDA approved for short-term use only, but has the disadvantages of allergic reaction in 30% of cases, which is quite a big portion, and it loses its effect after 2 to 3 months of use. Brimonidine has less allergic reaction and does not show less effect with prolonged use. Topical carbonic anhydrase inhibitors are dorzolamide, or Truzopt commercially, and brinzolamide, which is Azopt commercially. They have the problem of poor eye penetration with short intraocular staying time. But their advantages are decreasing the intraocular pressure by 20% with very low systemic effects, and their ability to be used as adjuvant to beta blockers. Their disadvantages are allergic reaction and the high cost. Now we come to prostaglandins and their analogues in treatment of glaucoma. Their action is mainly increasing the uveoscleral outflow. They have an early effect, which is via direct relaxation of the ciliary muscle with widening of the spaces at the extracellular matrix, and have a sustained effect via degradation of the extracellular matrix with reduction of its components within the uveoscleral pathway, and hence reduction of hydrostatic resistance to aqueous outflow. The dose is only once daily and better used at evening. The advantages is decreasing the intraocular pressure by 25 to 30%, and they are more potent than the beta blockers. The disadvantages are changes in the iris color. The iris may become heterogeneous with elongation and pigmentation of the eyelashes, with increased pigmentation of the periorbital skin, as well as eye redness. Prostaglandin analogs preparations are latanoprost, commercially Zalatan, at a concentration of 0.005% eye drops, and travoprost, commercially Travatan, at a slightly lower concentration of 0.004%. Uniprostone or Rescula has the action of increasing the uveoscleral outflow at a dose of 0.12% taken twice daily. Its advantages are increased blood flow to the back of the eye and a probable neuroprotective effect, therefore preventing ischemic changes. So, we can say that glaucoma treatment strategies are three. The first is lowering and stabilizing the intraocular pressure. Second is improving and stabilizing the ocular perfusion. And finally, neuroprotection, which is preventing nerve damage. And neuroprotective drugs are brimonidine, beta blockers like betaxolol, prostaglandins like uniprostone, calcium 2 plus channel blockers, and antioxidants. Now we shift to the final section in this lecture, which is ophthalmic anesthetics, and these are classified in ophthalmology into local anesthetics, topical anesthetics, and regional anesthetics. A local anesthetic used in ophthalmology must have the following properties to be considered as an ideal one: rapid onset of action, deep effect, adequate duration of action, reversible action, no pain while administered, no allergic reaction, no toxicity, and compatibility with other drugs. Further requirements for the eye include good penetration, no corneal damage, no effect on the pupil, and no vasodilatation. Topical anesthetics include proparacaine or ophthane at a concentration of 0.5%, binoxinate or binox at a concentration of 0.4%, and tetracaine or pontocaine at a concentration of 0.5%, with an onset of action after 1 minute of instillation and a duration of 10 to 20 minutes. Regional anesthetics include amino esters and aminoamides. Amino esters include procaine or novocaine, the concentration of 1 to 4%, chloroprocaine and tetracaine, having a low toxicity, rapid onset of action, and shorter duration, while lidocaine or xylocaine at a concentration of 1 to 2%, bupivacaine or marcaine at a concentration of 1/4 to 3/4%, or prilocaine have a greater toxicity and longer duration of action. Thank you very much.